Welcome back. This session is called Closing the Gap: Access, Ambulation, and Same Day Discharge in the EP Lab. It's a great topic, and we are joined by our presenters, Dr. David DeLurgio and Dr. Christian-Hendrik Heeger. Welcome. And to join the panel, we welcome Dr. Roland Tilz from Lübeck in Germany and Dr. Rahul Doshi from Scottsdale. Now it's over to David for the first of our two presentations.
Thank you very much, Devi. Well, I have the pleasure of speaking about multivenous closure in our current era. And these are my disclosures. I like to point out the major disruptors to EP in recent years that have really driven this forward. And COVID, I think, was the number one, occurring at a time where practices had to change in order to adapt to this crisis. And this meant freeing up hospital beds and redirecting hospital resources. There are other disruptors, though, that have been very important to us. At the same time that COVID began, we also learned that AFib is much more frequent than we had realized, that it is now a 1 in 3 lifetime risk for patients. We learned that if you treat by ablation, you get better results than if you treat with medications. And we also learned that dementia can be reduced and that dementia was an actual outcome of atrial fibrillation that had to be dealt with. And then we found that there was a sign of survival and stroke reduction. All these tended to drive our need for more and more AFib ablation. And the guidelines reflected this. As the guidelines came out, we now have first-line indications and also strong recommendations for treatment of patients with advanced conditions such as heart failure and even longstanding persistent atrial fibrillation. The next disruptor also really churning us here is Watchman device, left atrial appendage closure in general, and the emergence of pulse field ablation. These things all conspired to change the landscape dramatically, such that the incidence or need for AFib ablation really has gone up, as you can see from this study. And as we approach, this is up to the pandemic. As we go beyond the pandemic, we see these numbers just dramatically increasing. And this is a big strain on our resources. So how do we deal with this? This just also illustrates, just at my single center, the impact of some of these things. You can see that the monthly volume of AFib ablations and left atrial appendage closure just really climbing. This is up to August. It's continued to be an issue such that we're now at a place where it's actually the availability of the resources that are really the only limiting factor in getting patient care. Now, I wanted to show this slide about the major drivers of healthcare costs for AFib ablation. This is really important to realize. Of course, ablation equipment costs a lot of money, and anesthesia support costs a lot of money. And then there are facility costs. But I'm showing this slide to point out that things like the implant supplies are actually a very small portion of this. And so when we start to talk about multivenous closure, which does add cost, we're actually barely moving the needle overall. Our real opportunity is to decrease facility costs and these other relatively fixed items here so that we can be more efficient and actually save dollars overall while treating more patients with these conditions. Now, what is the biggest challenge right now? It is the staff and the availability of rooms. This is what is weighing hard on CFOs and CEOs across our country. And so we have to get to the point where we can make a difference. And that was what we were forced to do. And that's what multivenous closure has helped us do. So we found that if you use devices to close the venous sites, the risk of complications is reduced, as you can show both an early and extended follow-up. These are some sample devices, including the Perclose device, the Vascade device, the Minx. There are others, as you will learn. But these concepts, I think, all hold true, that if we can close the venous site and ambulate the patient early, be able to send the patient home shortly after the procedure is completed, and reduce reliance on hospital beds and more nursing staff, sheath pullers, et cetera, we can have a major impact. So you can see, why? Why do we do this? Manual closure was the standard forever. This resulted in a prolonged bed rest time and discomfort to the patient after the procedure. Figure of eight approaches have been around for a long time as well. It certainly has a very low supply cost. It does give hemostasis, but it's less comfort and requires that people interact with the patient to remove this stitch prior to discharge. We have a lot of experience with the Vascade MVP system and have studied extensively. We also have used the Minx system as well as PerClose. And all of these systems are designed really to improve patient comfort and they allow a patient to be discharged if needed in a shorter period of time frame, if only to get up earlier as well, in this concept of early ambulation. We found that there are some very big advantages when we use a system such as the collagen plugs because it can be taught to techs and nurses. If we have to do it, that's fine. Fellows can easily do it. There's no permanent product left behind. It has mechanisms of actions that make sense, such as physiological and mechanical mechanisms of action. And it allows us to close multiple sites on one side, which is relevant to current practice. We adopted venous vascular closure system at St. Joseph's Hospital primarily because of our interest in studying this, because we felt the need to be able to ambulate patients early and potentially send them home early, just thus freeing up important resources, as I mentioned. So we participated in the Ambulate family of trials, which has shown the safety, very low adverse events, and the feasibility of early ambulation and discharge. We initially had pushback from the hospital system because there is a cost associated with these things. But when COVID came along, it became clear that we would save money and keep our patients getting treated by using this concept of early ambulation and same day discharge. And that was what was really just a watershed for us in our facilities. And I think many other facilities have experienced the same thing. So before we would have sheets pulled in the recovery lab. Now we just do the closure at the very end of the procedure in the EP lab. It requires very little time. We use primarily the Vascade family of products, but we use other products as well. And we ambulate within 2 hours, and 95% of patients will go home in the same day. Whereas before, every patient stayed overnight, if you can believe it. It seems like ancient history. Now only patients who have either medical or strong social reasons would stay overnight after one of these procedures. We all very interested. If you think of the PFA and the left atrial appendage closure era, we're talking about large bore devices. So we've been very involved, as well as other sites, in the research of larger bore closure devices that can deal with the larger PFA catheters and the left atrial appendage closure. And we have studied extensively this concept of a larger collagen plug and a larger disc on the device. The Vascade MVP looks like this. It has a disc size of 25 French on the XL device. So you're able to get hemostasis before you've uncovered the collagen in very large size holes. And this covers for us all of our left atrial appendage closure and PFA cases. And the what they're seeking for approval is sort of this 15 French OD, but we use it exclusively in patients with 17 French OD. And we've been studying that at our center, and we've been finding that it's quite effective. And it has been studied and reported by Dr. Natali's group, showing that it can easily close those size holes and with essentially no major complications, as you see here, no hematomas. People say that sometimes closure devices will ooze, and I think that's important to realize that the closure devices that we're talking about, they close the venous puncture, but they don't necessarily close what happens at the very surface of the skin. So sometimes you'll see a tiny bit of bleeding from the skin itself, but this is not the same as vascular leaking, and certainly it's not associated with a hematoma. So this has been a really big step forward to use these larger bore type of devices that have a larger collagen plug and disc. And I don't know if you can play this. It doesn't look like it's going well. Okay. So here what we're showing is a comparison of the FaraDrive catheter and also the TrueSteer catheter. This is a concomitant case where we started with a FARADRIVE case and finished with a TruSteer catheter. So this has a 17 French OD or even 17.1, I think. This is easily closed, and this makes our life much easier because concomitant patients will go home the same day, just like any left atrial appendage closure case and just like any AFib ablation case. And the process for putting it in, I don't know why it's rotated off to the side or located, but it's very simple. If you could play that for me, I have no control over that. So all we're doing is putting a long guide wire through this, in this case, a FARADRIVE sheath after the ablation. And then the sheath can be, wire is retained. It's interesting that once you take out the larger sheath, the hole starts to retract actually and get smaller. This has been shown. So I'm inserting a 10 French sheath, short sheath that we had left over from the beginning of the case over the guide wire into the puncture site. And then it's just a matter of putting in the large bore closure system. It's advanced into the vasculature. The disc is therefore deployed and the sheath is removed. And we should be able to show that you have instant hemostasis temporarily just by pulling the disc back about against the venotomy site from within. And that's uncovering the collagen plug right there. And in 30 seconds, that will expand to something like 16 times its regular size. And then that can be deployed. We've studied and will be reporting a clinical trial of the device in this use. We've already used it over 1,000 times in this scenario, but this is the formal clinical trial called Ambulate Expand. You can see the types of patients, and we used all these different types of sheaths, including the large 17 plus OD sheaths. And we'll be reporting the findings of this at AFib Symposium, so stay tuned. But this is a really important advance in our current era. So the disruptors that have happened have really changed us. It's the guidelines, the concept of early ablation, ablation and heart failure, the data that shows the efficacy of this approach. So we have limited hospital resources. What do? We really need efficiencies. And what we found is that having multivenous closure really is the fourth disruptor because it's really one of the technologies that has made all of this possible. Thank you very much.
Christian, now it's over to you for your presentation before we take questions.
Of course. Thank you very much for the invitation, Devi. I'm very happy and proud to be here at RIO. So I'm the second speaker here. So thank you very much for the invitation. And also my topic is access, ambulation, and same-day discharge in the EP lab. And these are my disclosures. So what could be preventing us for sending our patients home on the same day? Of course, this might be, or this topic are complications. And so the question is, are we ready for same-day discharge? And the complications are written here. So in my opinion, tamponates are extremely rare during our procedures now in these times. PV stenosis, fistulas, and phrenic nerve palsy are also usually not any problem anymore with PFA. So non-severe complications are non-severe, so maybe not preventing us for sending them home. Death is extremely rare. Strokes and TIA also very rare. Severe complications are very rare as well. And only the big topic and also of my talk today is vascular complications. And these are the main topic of preventing us for sending them home. So how can we, how did we change? So in the last years, 2013 until 2017, the complications definitely were less. So we did a very good job in comparison 2018 to 2022. So we did a good job in reducing complications, but not for the vascular complications. So here, as you see here, the different time points, there's no change. So we did not change the vascular complications. So how can we reduce them? In my opinion, we should do two things. So we can combine two things for reduction of vascular complications. The first topic is extremely important, and there are many studies on this. So it's ultrasound guided puncture. And so this is the Ulysses study. It's a randomized controlled study from Germany. And this study is a very large scale study, and we are also part of it. And hopefully we will show that ultrasound guided puncture is reducing complications. And the other topic is to use venous closure management. And the management should be figure of 8 or also closure devices like ProStyle. And there are some studies proving this, ProPVI and StyleRF study from Roland Tilz. Then the Vascade MVP device, we just got a presentation on this very nice device, and we're doing the VASC AF study here in my clinic in Altona in Hamburg. And then the third device is the PerQseal device, and we were very happy to do some procedures, and I will explain this device to you very soon. So the Vascade MVP system, we just heard about this system already. So it was evaluated in 5 EP clinical trials in the US. So more than 1,000 patients were included in these 5 trials, and 0 major complications were observed. So it might be very, very safe to use this device. The PerQseal Elite device is a novel device for very large bore or large bore access. So you can use it for arterial sheath, like you see here, 14 until 24 French for arterial, but also for venous closure, 14 until 30 French. So it's very big. And the current status is it got CE mark this year and is submitted to FDA approval also. So let's see what we can do with this device. So this is an overview of different large whole venous applications. And you see on the left side, there's PFO, LAA closure, cryoablation, PFA. You don't need very big devices for this. But if you go further, you see also micra. And this is also a very common procedure for EPs currently, RVL procedures, then ECMO, impeller, but also very large scale valve replacements and valve treatments. And you can close all these holes with the PerQseal Elite device. What kind of device is this? So it's a patch-based closure system. So you have 2 patches. One patch is inside the vessel, and the other patch is outside the vessel, and it's 100% bioabsorbable. So you can get the return of the artery to a natural state after about half a year. You have a patch inside the vessel and 1 patch outside the vessel, and you don't need to do any pre-procedural steps. You can just do your procedure, and in the end, you put this device. And I will show you a short live in the box video of this device very soon. So it's completely bioabsorbable. After 32 days, it's still visible. So you see the plate in the left side here. That's a very large plate. After 90 days, it's almost gone. So it's not really seeable anymore. And after 180 days, the vessel is completely normalized. So there is already also some data. On the left side, you see data on the Elite study. This was done for arteriotomies, so in arteries. 120 patients were treated. But let's focus on the venous side since we are EPs. So the Elite venous study was based on mainly venous procedures in 97 patients in the EU and also with 6 months follow-up, and the venotomies were about 14 until 26 French, so quite big. Concerning the outcome, you see on the right side the Elite venous study. So it has been used for TEER, for left atrial appendage closure, and also for mitral valve interventions. The outcome was quite good. For the artery, there was 0 major complications. For the venous study, there was a very low amount of complications, just 1.2%. If you see about the complications, and also mainly same-day discharge. The issue seems to be deep vein thrombosis for this device, because all these complications were deep vein thrombosis. I did a few cases. I have not seen this, but this might be an issue. Concerning the hemostasis, look on the right side. We found an immediate hemostasis, so 0 minutes in 95%, so which is quite nice. You have an immediate hemostasis for your patients with this device. So this is a short live in the box video I did in my clinic. So I was able to do the first EP cases with this Percusil Elite device. Could you start the video, or can I start it? Try to start, yeah. So it's Percusil Elite device. As you see here, I did a Power Pulse procedure with the Power Drive sheath. So it's almost 17 French outer diameter sheath. And just in the end of this procedure, I put the introducer via a long wire to the groin, to the vein. And after putting the introducer to the vessel, you just have to find the correct position. So we need to position the introducer by playing around. You need to find a stable and safe position. This is after a learning curve of, let's say, 3 or 5 cases. It's very easy to find, to get the perfect position. And then the Percusil Elite device needs to be prepared. You need to get some water into this device. Then you get it into the introducer, as you see here. That's the device. And then it's over the wire based. So you need to get the closure device on the wire, as you see here. You connect it to the introducer, and then it's quite easy. There are numbers on the device. You know this also from other closure systems. So on this device, there are 6 numbers, and you have to follow them. It's very easy. It's written on the device what you have to do, and it takes about, let's say, 30 seconds. So it's extremely easy and extremely fast. And now you see the whole device is now get out of the groin, and as you see here, we have perfect result, immediate hemostasis, and same-day discharge ready. So I will go further. So we did 25 cases, but since we like to show this 25 cases at some meetings in the future, maybe at Boston AF, it was first in man experience for EP procedures. We did this in my clinic. So I would like to show you 11 patients. So we did this all in Power Drive, Power Pulse procedures. Mean age was 62 years. The median procedure time was 30 minutes. The median pressure bandage time was rather short, so 120 minutes, and we had no vascular access complications in these 11 patients. And stay tuned, we will give you more data on our first 25 patients in the future. So how did our workflow change with vascular closure devices? So before we got vascular closure devices, we used the figure of 8 and pressure bandage of about 8 hours. Then we have to remove the stitches on the next day, and this was in many cases painful for the patients and also for my staff. So what we are doing now, we use Vascade MVP, ProStyle, and Percusil to our pressure bandage. We don't have to remove any stitches. The patients are happy, the nurses and the physicians as well, and we are same-day discharge ready with these systems. Let me conclude. The main complication in EP procedures are vascular access related. If you combine ultrasound-guided puncture and vascular closure systems, you could improve safety for our procedures. The Percusil system is patch-based. It's a novel vascular closure device for large bore sheath. The advantages are that it's completely bioabsorbable. You have an inside and outside patch, and you can use it for very large bore until 30 French. And as I just said, AF ablation in 2025, same-day discharge ready. And I'm happy to do some discussion with you.
Well, thank you, David and Christian, for those wonderful presentations. Rahul, let me bring you in and ask you the first question, because you always will give me an answer that'll make me wonder. How, everything comes with a cost. All these vascular closure systems come with a cost. And, we are entering into an era, at least in the US, for things such as ASCs. Is the cost of a closure device justified by this reduced monitoring time and these fewer complications that we saw in these presentations and maybe higher throughput? How should health systems analyze this value?
I think the way to answer that question, I mean, and Dave already presented the economics behind it quite nicely, I thought. But so let's go one extreme, right? So healthcare system is, you know, large expenses, large volumes, big footprint, et cetera. If you bring up the ASC argument, where okay, now we're maybe talking about smaller time or smaller uh, organizations or groups, or certainly people that traditionally are more certainly paying attention to cost much more, right? And certainly the reimbursement is going to be less, and so the margins will be that much less, and so you're really going to pay attention to cost. I still think that the efficiency piece more than pays for itself, as I think Dave nicely outlined. And my concern is not just the fact that, well, I mean, I could argue all day that the economics make sense, but I think it would be a mistake for the EP community moving into the ASC to give up. I mean, it's Christian presented so beautifully the safety outcomes as well as David, right? Is that safety should be the primary concern, and these devices are safer. I think the point that Christian illustrated so nicely is the fact that vascular complications are still driving the number of complications for these procedures, and these devices decrease that. So, regardless of the economic implications, which I think are still sound for early discharge, for increased throughput, increased efficiency, the safety still greatly outweighs it in my mind.
I
I
think
completely agree.
Roland can also talk on this topic because he just published an analysis on the ProStyle device from the Style AF study. So it's definitely economic valuable, Roland, right?
Yeah, I mean, what you refer to is the cost analysis of the randomized Style AF study, where we randomized using the ProStyle device versus a figure of 8 stitch, and you need less. You have a faster time to ambulation. You have faster time to discharge eligibility and an extremely low complication rate in both arms. And that's why it is cost effective in a competitive surrounding. And I think the great value is, as Christian already mentioned, in the same-day discharge environment. Germany used to be an inpatient used to have an inpatient environment for AF ablation. Everything is going to change on January 1st. I'm really looking forward to it. And then I think the closure devices are going to be even more important.
Roland, while I still have you, let me ask you a question about what are the factors that guide your choice between these closure systems? I mean, there's collagen-based systems that we just saw, suture systems, I mean, figure of 8. Like, is it the anatomy? Is it sheet size? Patient comorbidity, workflow, center? Like, what is it that lets you pick?
So at present time, for our hospital protocol is that if it is an inpatient patient, we don't use the closure device, but use a figure of 8 stitch for cost reasons, because he's going to stay in the hospital bed anyway. For outpatient patients or same-day discharge patient, we do use a closure device. And in Germany, there is not a big choice for devices that are approved for venous devices. And this is why we use suture-based device as a standard of care. The only exception is for arterial. So if you use an impeller for VT ablation, there we would typically use a combination of both. So you use suture-based device initially, and then a plug on top of it. And there we have very great experience. So it's off-label, but highly effective.
All right. Wow. Okay. David, let me ask you a question about repeat procedures. I think, as these repeat procedures become more and more common, what is your level of confidence when reaccessing the femoral sites previously closed by some of these new Vascade platforms and closure technologies? And one more thing.
Well,
is
so far,
are there any anatomical changes that you look for as well?
So there are no visible anatomic changes in the time frame for redo procedures. In other words, 60 days after a collagen plug is essentially there is absolutely no ultrasonographer difference that we can see. There is no suture, which could make a small difference. The collagen, like other similar platforms, is fully resorbable, and so and it's extravascular to start with. So we haven't been able to see any vascular changes on patients who have had redos. I feel very comfortable that that's not an issue. I think with all these devices, there is a small learning curve. Thankfully, it's pretty short with most of them to make sure you're deploying it properly. We train our fellows in this, and in some of our hospitals, we actually are having techs involved in the takedown of the devices, not necessarily the deployment of the devices. So this gives us added benefit as well, that these things are very usable and very simple once you understand how they work.
Okay. Rahul, let me ask you the final question of this session, and actually the final question of for almost final question of Rio. Uh, we look at the US, at least Germany has a reason to not have same day discharge. They're not allowed. In the US, it's a different story. I mean, we've done same day discharge in this country for a long time in some centers, and then COVID kind of made things faster. But why do some high volume centers achieve like routine same day discharge while equally capable labs just cannot? And do you think there are like key systemic or cultural barriers or something else? Is it an adaptation problem?
I really do think it's an adoption problem, right? I mean, it's let's face it, these are simple solutions. It's just getting over the hurdle of doing it, right? I honestly don't think that there's a system out there that is not capable of doing this, right? I mean, these are very simple solutions, and I'll speak for our network or our institutions. If we could do it, I think anybody can. And as David illustrated, I mean, we were forced to do this with COVID. And it's just getting over that initial hurdle, and then it just becomes now routine practice. And it's as simple as that.
Well,
Yes.
with that, I have to say that we're about time and running out of time for this session. So thank you so much, David and Christian, for that wonderful presentation. And thank you, Rahul and Roland, for your insightful thoughts. Stay with us. The final session of Rio 2025 is coming right up.